We can probably get started. I don't know how many people are going to have joining us, but just kind of a reintroduction of what this group is. I mean, it's a casual discussion, completely open discussion about ways to kind of maximize treatment strategies and optimize outcomes for these patients. Everybody on this call is somebody who's either just getting started with it or has been using it for a while. So let me turn my TV off. So yeah. Kind of case-based discussion. So I figured we kind of go around. I know a couple of us have prepped some cases. I'll start just to kind of to lead it off. I've got a real short case that I can share that nothing special, but kind of interesting with a little bit of a nuance to it. All right. You guys got my screen now?
Yeah.
Yeah.
Okay, cool. So this is a lady that we did not long ago, I think her surgery was maybe a couple months ago. 59-year-old super high myope. So she came in and obviously, I'll spare the discussion. I mean, we're here to talk about the LAL. So we had talked about options and everything, and she wanted high visual quality with functional reading, but distance was really going to be her goal. So with her, our scans, I mean, look at her OCT. Those eyeballs are super, super long. And she does have some foveal irregularity. Both maculas there. And if you look at just the thickness map, I think that really tells a better picture about how irregular her foveas or her maculas are. So anyways, long story short, went with the LAL. Here's her pentacams. This really doesn't show anything crazy. A little bit of astigmatism, very symmetrical, very regular, nothing crazy there. And then her operative data. So axial length 30, very long. We picked 4 diopter lenses, pretty much as low as we can go almost, and ended up going with an LAL. So the tricky sort of the ambiguity of this case comes with the treatments, and this is kind of what I wanted to talk about. So when she came in, we actually nailed her right eye. She was dead on plano. So she's 20/20 in the right eye. Her left eye is 20/30. We ended up myopic in the left eye. So right out of the box, she's like, holy crap, like this is great. She's super, super happy. I think if we're splitting hairs, the big thing that she wanted was maybe a little bit better reading. She was J1. She was very functional up close, but she did want it to be a little bit better. So the first question I have, how do you guys handle cases like this? When you talk to patients about when your surgeon almost does too good of a job. I always get a little bit upset with my surgeon when we hit it right out of the box because he steals my thunder. And I joke with my patients like, yeah, shoot, you paid for this fancy lens. My surgeon was just too good. I could have asked him to be less good, but he stole my thunder. So here we are. I guess I want to open it up to the group. I mean, how do you guys handle this? How do you spin it?
I like to.
Oh, good.
I'll tell you, I treat it as if we were fitting multifocals and giving them the opportunity, right? It's like an insurance policy, right? Yeah. We have the opportunity to make changes if we have to. We don't have to. Mm-hmm. Is that what everyone else is doing?
Mm-hmm. Yeah,
that's
explain,
right,
less is more. You don't want to just change. You don't want to do a treatment just to do a treatment. It's nice to have it in your pocket in case we need to, but don't fix what's not broke.
Yeah, I mean, with her, I always try to put this in a way of you paid for the outcome, not necessarily the process. The process is the appeal, and now we have the ability to at least talk about it and change, but you paid for the outcome. So for her, we're at plano. I did do a treatment, a neutral treatment, just to start the polymerization process on the right eye. She did want more reading on the left eye. What would you guys target as your left eye? If you're at -75, how far would you go, and how would you do it, understanding that if you go in a myopic direction, you're going to set off the added depth of focus?
Did you trial there? I got a question. Did you trial, sometimes in these folks, I might throw like a +50 contact lens on that left eye and send them home?
I don't love doing contacts. I think Ron, and Ken, I know you guys do contacts a lot. I don't love doing contacts only because it's burned me in the past where I've had patients almost get hyper fixated on quarter steps and think about it too much to get in their head. I gave her a trial frame for sure. And we did a little bit of trial framing. I think I put over a +50 and just see, is this what what you want? And she said, yeah, this is better. How would you handle it though? So everybody on this group probably is aware, if you go in the myopic direction at -50 or greater, you're going to add negative spherical aberration. A small amount, but definitely something that could be substantial. In
You
a patient
could
like this, yeah,
bypass it by tricking the system. So if you want to just induce the 50 without the spherical aberration, then you could say that her manifest was a +50 and you're targeting plano. And then that way you don't trigger the extended depth of focus or the spherical aberration, so that just in case you want to go back and you want that crisp vision, you're still solid. Because that's one thing that's burned me in the past too, is kind of triggering that spherical aberration, and then like, oh, I changed my mind, I want to go back to where we were. I'm like, there's no going back. Once you've put that aberration in there, they're always going to have some of that glare and halo, a little bit of that shadowing. So I like to err on the safe side now if you don't want to induce any of that.
ding, ding, ding. Jenny, you're so smart. That's brilliant. That's exactly what I did.
I've been burned.
Yeah, that's what I did. So I tricked the system. So I typed in my refraction as +1/4, and -50 is our threshold. As long as we're not getting to -50, you're not inducing that negative spherical aberration. So I wanted a delta of 0.5. So effectively, my end point with this, if we hit it dead on, would have been -1.25. Because with her macula, the way it looked, I get a little bit nervous, especially with a long eyeball. You never really know. And I didn't want to do something that you can't undo. So I often do this for patients who are non-committal to the blend. You know, if they're like, well, I don't know if I really want to do a blend. I don't know if I'm gonna tolerate it enough. I think I want to try it, but I may change my mind. If you do that added spherical aberration, you really can't undo that. And most people are pretty tolerant, but yeah, Jenny, like you, I've been burned too, where I've done it and you can't undo it. And then I will always be just a little bit, especially for our type AAA engineers that this lens naturally will draw, those patients are going to perceive it. And so if you can avoid it, I would recommend tricking the system like I did here.
Mhm.
The
Nick,
yeah.
one of the issues with high myopic refractions in general is that because the patient has some form of posterior staphyloma at that length, whether you observed it or not, I mean, just look at the OCT, the OCT output on the analysis. I mean, that end is the device searching for a better analysis, which it can't give. One of the difficulties is that you can refract that patient multiple times and not end up with the same refraction, depending on where in that trough you are actually having them fixate. And many of them are not monofixators, as you all know. I find that in these patients, it's best to do an anaglyph refraction, go red-green, and that will give you the ultimate capacity to plant the image both equally in front and in back of wherever they're looking. And I think you might end up with a little more accurate refraction. Sometimes just the accurate refraction seems to be sufficient to deal with the issue. These are tough patients. They're tough patients if you're not doing LALs. They're just tough patients to work with.
That's a good point. I think doing a red green would have been a smart move. I didn't. I usually, when I refract these patients, because you're totally right. I mean, the retina is just so stretched out that your end point is so fluid and very soft. And so you kind of end up having to bracket. But I could have done that. You're totally right. But if you're inducing spherical aberration, you can end up having kind of a circle of blur.
Yeah.
Can I ask you a question, Nick?
Yeah.
So, you know, you had a very nice spherical refraction there. Now, and if we wanted to trick the system and we had some SIL that we wanted to correct for as well, I'm assuming you would put the SIL in your treatment as well, but you would just make it more hyperopic to avoid the -0.5, or so you would do like +1/4 in addition to your, like, let's say half diopter of SIL.
Yes, yeah, so I would. So in order to induce the spherical aberration, both meridians have to either steepen or stay neutral. So you can't be flattening your meridians to do that. So yeah, I would have put the cylinder in my hyperopic MR and then targeted something lower than the threshold of -50.
Right. Okay. Sounds good. Thanks.
Make sense? Yeah. So yeah, that's what we ended up doing. But I think, Jim, to your point, the refraction probably was pretty fluid. because we ended up missing quite a bit. Her right eye still plano, so that's good. That's the one that really matters, her distance eye. But her left eye, we ended up way overshooting. She was negative 1.75. And she came in, she's like, I don't want this much. I don't know what happened. And I was like, well, I don't know. You got a big eyeball. We may have just refracted it poorly. Not a big deal. We can fix it. And that's what we ended up going back. She wanted to go back to where she was previously, so negative 75. Once we did some trial frames, I trial framed a negative 50 over top of her MR just to put her back at negative 1.25, or simulated at least. And then she wanted to go even further back, basically where she was before we did anything. So long story short, we ended up kind of where she wanted to be. So she was negative 75 in the non-dominant, plano in the dominant 20/20, very happy final lock. So I just wanted to illustrate kind of what it looks like if you do want to trick the system, because it's possible. And I think it's something that you should take advantage of if you've got somebody who does have potential compromise on the retina or cornea, or is just non-committal to the blend. Any questions or anything? Any other comments?
Actually, I love the idea of pushing. Now, how much, for all of you, how much plus can you push to reduce the risk of inducing aberrations on the backside with the myopia? Is it a half? Is it 3/4? I mean, where's the upper limit of that? This is a lot like registering the patient as an 18-year-old when they're 14 on the OCT to get a reading. You know, you're sort of tricking the system. I don't know whether that's, I don't know if we have enough data to know that that's a really good thing, but it sounds great. I mean, I love the idea of that, because it gets away from some of the downside stream problems with those higher myopes. So is there a number that you can't go past?
You just can't go past negative 50 as your target. That's the trigger for the system.
Oh, okay.
Or you
Yeah,
can't,
so what,
can't trigger, or you can't have a negative 50 target or higher. So you want to avoid plugging in a minus 0.5 with the delta change on that first treatment.
Okay. So if you went to plus a half, that would still give you a half in the bucket if you wanted to do a little bit more.
Yeah.
Okay.
yeah, 'cause you could go plus. I mean, it's the delta that the machine is trying to outsmart you. It's this weird game that the machine does, but it's the delta that matters.
Okay.
You're smarter than the machine.
And I'm sorry, Nick, I'm a little bit behind, I guess. I don't understand how the spherical aberration is induced and what that produces for the patient, and also how tricking the system minimizes the spherical aberration induced. Can you explain that for me?
Yeah, so if you're moving in the myopic direction, so say your
Yeah.
MR is plus 1/4 and your target is negative 50 or more myopic,
Mm-hmm.
that will induce about an added quarter to, I think it's 3/8 technically, negative spherical aberration. And what that does is it broadens the depth of focus. So
Okay.
that should afford you wouldn't need to go further myopic in those patients to get the functional range of vision up close. So you don't want to do that. Spherical aberration is a great thing in a healthy eye, but in an aberrated eye, or an eye that doesn't have a perfect macula, that's just optical noise, and it's going to compromise their contrast and their overall quality of the vision. So you want to avoid it. So tricking the system is a way to get a myopic shift without adding that depth of focus if you don't want it.
Okay. And how exactly, when you trick the system by changing, the numbers, how does that not induce that myopic shift in spherical aberration? I just don't understand how.
Because you have
Also,
to hit all of those variables before
Mhm.
it triggers it. So if you don't have a minus 0.5 target, and or you don't move in a 0.5 or larger, then it doesn't trigger it. So
Okay.
that's why you want to target either a minus 20.25 or more hyperopic, and then
Okay.
you won't trigger it.
Oh, interesting. Okay.
And that's
Yeah,
just
so-
as a reminder, that's mostly on the first adjustment where the machine will trigger that.
Okay.
Okay.
that's
Like
a-
subsequent adjustments, you're not so worried.
Yeah. So you could go like, if I want to go like a $1.25, but I don't want to add the depth of focus, I could do my MR, I could type in as +1 and my target as -1/4. That delta is 1.25. You're still not going to induce that negative spherical aberration on the first treatment. That's a good point, Ken. It's on the first treatment only. The second, third, and subsequent ones doesn't matter. It's only on the first one.
Interesting.
And I don't know if, I think I would err on the safe side of that too, just because I say they say that's the parameters, but I don't know if I'd shoot for that entire $1.25 during that first treatment, just in case, because I feel like that's a big change and that might be too much to trick this, you know, like I like to maybe like go just like you did, like a plus 50 to Plano, like 0.5 delta at the very most on the first treatment, just in case. Because they say, I feel like things have changed and they don't have a solid answer. They're like, they say this is the parameters of not inducing it, but I feel like some of my patients still got it even, you know, like if we go too much. So
Yeah, I
I say
think
on
you
that
Only
can
in
very
your
first
direction
treatment,
on that.
yeah, on the dominant eye, or if you have any, you know, a lot of ocular noise, then err on the safe side and have a smaller delta on that first treatment. And then you can go wild on the second, third, and fourth treatments.
So I've also heard of doctors doing this where they, again, trick the system and induce negative spherical aberration in both eyes. I would highly advise not to do that. So what you could do theoretically is, you know, go from your whatever, let's say Plano right out of the box, you could go down to -50 on your first treatment. That induces the spherical aberration, and then back them off targeting Plano. So refractively, lower order aberrations, myopically, you're at Plano, but now you've got built-in spherical aberration to theoretically enhance the depth of focus further. I would not recommend it. I've heard of doctors doing it and getting burned, because then you do have, again, you have a compromised distance. It's like you're looking through like a depth of focus lens, like a need off or a symphony or something like that. You're going to start to have glare compromised distance, and you're only getting probably about 3/8 of a diopter of depth of focus. It's not substantial. The lens already has some baked into it. So in my experience, at least in my opinion, I would not recommend doing it. I don't know if anybody else would disagree.
Now, I agree with you. Speaking as someone with the lenses in my eyes, we set off the negative SA in my non-dominant eye, and I appreciate it. And it took me a little getting used to at first. I mean, I understood what was going on. I would not want that in my dominant eye in any way. Because there is a difference on that distance, and it's the way I describe it is I can see all the details, but just like a license plate will kind of pop out of the fog on that left eye that it doesn't do on the right. I don't know if that makes sense to everybody, but it's something that I would avoid that. I totally on your side on that, Nick.
Yeah.
And
Almost
to
wasting the
clarify
optics
what
of it.
Nick said, the negative SA is only induced on the LAL plus lenses. The regular LAL lens does not have it built in, for those that don't know.
There's a little bit built in, I think. It's not much. There's more in the LAL plus.
Right,
But you can
very
still,
insignificant compared to the LAL
Yeah.
plus.
So
Yeah.
Brian, I have a question for you. You have the plus in both of your eyes. Is that correct?
Yes.
Okay, so your dominant eye, that's Plano, the built-in spherical aberrations, that is not affecting your distance vision.
No, it's negligible, and I have very spherical corneas. I was I was wondering about that because I don't have a lot of aberration in my corneas or anything naturally. But no, it's not much at all. But I could tell when we set it off in the other eye. I was like, oh, that's what everybody's talking about. And I actually went back a little, and I landed right where we first put me. I played with mine a little bit. And it did make me much more aware of paying attention to my patient's personality type and a few other things about setting off that SA. So I used to do it just automatically, and I came late to the party. Actually, Jennifer, Nick, and these guys all kind of brought me forward. I was like, oh, I see what they're talking about here, and I'm much more cognizant of it now.
So can I ask a question? Does anybody, I mean, this is a very remarkable discussion. Thanks for including me, but is anybody using contrast sensitivity, acuity to measure these subtleties that you're discussing while you're in progress of doing the treatments? does this affect contrast sensitivity as far as the patient? Because it sounds to me like these SAs, to some degree, are being observed, or the patient's been made aware of them because they're changing contrast sensitivity, but not functional smell and acuity to a large degree. Has that work been done by anybody? Not us, just anybody.
We were testing it in the beginning and we were gonna, but there's just not enough change to.
Okay.
Yeah.
So it was
It
it
does
wasn't
affect it,
statistically in that model. Okay.
Yes.
So we have the iTrace unit where we can test their modular transfer function and their depth of focus curves, and it's interesting. I mean, I don't have a very, very big N number at this point, but it seems, at least anecdotally, our initial impression is with the LAL plus that they tend to lose some of the contrast compared to the LAL. And so we've been putting in the LAL, the first version, into the dominant eye, and then the LAL plus in their non-dominant eye.
I would also encourage a lot of your surgeons to ease up on the LAL plus if they're really jumping into it now, just because if the patient has any ocular conditions, even just dry eye, any ERMs, any retinal issues, any corneal issue, basically anything other than a very clean cornea, I would avoid the LAL plus because it's not adding enough gain. And we're having patients complain about glare and halos at night. Overall acuity just isn't very sharp for distance and near. And it's like, why? I don't know. If anything, put it in the non-dominant eye or just stick with LAL.
And so do you think this is an issue that surgeons don't understand or haven't been taught to understand, I guess would be a better way to phrase it?
I think so. I mean, we were pretty gung-ho about the LAL plus. The LAL plus, I don't want to talk bad about it. We use it. It's probably 50-50, maybe a little bit more skewed towards LAL. If you would put a EDOF or multifocal lens into an eye, I think you can comfortably put an LAL plus in. If the cornea is pristine, if the retina is good, there's nothing, there's no high corneal astigmatism. We were very aggressive with LAL plus. We were part of the original study, and we saw, with the original study, we were putting this naturally in patients who were healthy, and we had outstanding results. But we did, especially post LASIK, that was kind of our first dip into the waters of irregularity, myopic LASIK. And we quickly realized that I think we were getting some, patients were so happy, but it wasn't as crisp of a distance acuity as it was with a standard LAL. So I think there's still kind of a wealth of understanding that's happening. And so, we have, at least I work with one surgeon. I don't work with several. Jenny, I know you work with like 50 surgeons. So education is important there with that. But we're 50-50, maybe a little bit less LAL plus compared to LAL.
I don't know if you guys have.
Go ahead.
Oh, go ahead.
I was just going to ask Nick, do you ever mix and mingle? Do you do the dominant eye LAL or
No.
the non-dominant plus?
No, and you can. I understand that theory and that strategy. My philosophy is that eye dominance can change, and I've seen it happen several times where I've got patients who come in and they're, they think they're right eye dominant, especially in Wisconsin. I mean, everybody's got a shotgun or a rifle, so I always ask them where they scope.
Same in Texas.
Yeah. And I was like, my right eye, and then once we do surgery.
Guys, I could use a little help. They don't allow us to do that here. So
yeah, everybody comes in. I'm just lucky they don't bring it into the clinic with them. But yeah. So I always ask them, what do you scope? And that's kind of our go-to. But I mean, I've had plenty of people, and we're talking like at least probably 5-10% of patients that we've done where it flips, or they don't want to commit to a blend. And so I think, at least my philosophy is that if you commit to an LAL plus in a non-dominant eye, you're committing to that eye being just ever so slightly worse at a distance and potentially some contrast loss. Because I think, Jim, you're right. I think we are giving up some contrast. We don't test it, but I'm sure it's happening if you did look for it. And so I think you're committing to that by doing a mix and match. So we don't. Does anybody else does that make sense, or am I crazy?
No, we're not mixing right now. I have some concerns about that because I've had some patients flip. I don't want to even accentuate the difference. If I have an LAL in one and a plus in the other, I'm not sure I want to accentuate the difference between them. I have, obviously it's being done. I myself, I was nervous about it. We've been doing a lot of plus, and we've actually are having discussions about, doing, we keep the LAL as a choice on our sheets when we're counseling, and about we're trying to come up with, I love what Dr. Wong said. It just helps me to start to kind of weed out, like, let's think about the regular LAL versus the plus on some of these more irregular corneas and things like that. Because I have a concern but mixing them, we haven't done that yet.
Yeah, I prefer them just to go back to LAL, but these are the doctors that were like really wanting to use it, and most of them are falling off now and just going back to LAL just because we've had explants. I mean, it's that bad that patients are
It's
out.
interesting because our office here, we do LAL plus in almost every single patient, whether they've had LASIK or any kind of irregularity, but I never induce negative SA anymore. I've left that off the table. I felt that didn't give us much extra, and the risk of having a patient have a problem with inducing the negative SA just wasn't worth it. But it's very rare that we have an explant with an LAL plus lens, and my surgeon, he'll put them in RK patients. All patients almost will have the LAL plus lens, and we have not had the explant issue. And it's interesting hearing others saying that that's been more of a problem for you guys, but you're great results here.
Yeah, Joe, so did you say for the first adjustment you're not activating that extra EDOF for any of your patients then?
No, I did do a study. We did a study here for RxSight too, and at the beginning we got the LAL plus lens early to kind of do that study. And I have a very high caseload here, and one of our other sites, they felt like they were having issues when they were inducing the negative SA. And so I actually just stopped doing that and didn't want to formulate a bunch of problems and just did it no extra inducing. And we were finding that our results were, J1 plus, 20/20 at distance, and 20/25 at that computer zone, and the vast majority are very satisfied. And so I just kind of left it at that. And for a while, I felt like, I was leaving something on the table, just wasn't giving the patient the best by not inducing that negative SA. But when I would do it occasionally for a patient, the end result just appeared to be the same. And really not like a very strong difference for us to say, let's induce negative SA on this patient or that patient. We just kind of made it more simple. And we always, fake out the system to never induce it. And that just seems to work better for us here.
So I just have a quick question regarding that, Joe. And Dr. Wong, you can also jump into this. So like Joe, you're actually placing the plus in for like almost all eyes, or at least you're having a really good amount of success with it. Dr. Wong, you're a bit more on the cautionary side there. In terms of patient selection, do you think that like you two are doing something different for the plus itself? Like, I mean, Joe, like you said that you did it for like, even for like an RK, and Dr. Wong, which patient did you have to do like an explant for? I mean, like was that patient out of your normal selection process for the plus itself?
Yeah, they had basement membrane dystrophy, ERM, retinal issues were in play, severe dry eye. I have had some cases that are fine, but they're pristine eyes. There's no dry eye, there's nothing in the back of the eye. So it has to be like a nice, clean eye in our case. But it's been there's been too many cases for it to just be a coincidence, because they're all LAL pluses, and they're coming in with the same exact complaints of glare and halo at night. Things are just not as crisp. There's a fuzz along everything. So we've deduced it down to, it's the LAL plus, and then several of them had them explanted and then they replanted an LAL, totally fine.
We've got 20 minutes left. Does anybody else want to share a case?
I have a case I want to just put out there. Eric and I
Yeah.
did something fairly cool not that long ago. We had an extremely high hyperope. I think she was about a plus 15 or 16. So there was no lens on the platform for standard lenses that gave her the full correction. So we actually ended up piggybacking the LAL over a standard high hyperopic lens. And that gave us the ability to create the adjustment at the end, which really zoomed her in literally and figuratively. She ended up at plus a half, minus a half in one eye on the surgery. And then we adjusted that. So she's pretty much plano in her distance eye now with excellent acuity. I thought that was very creative. And I don't know if that's a common thing that we can do, but the LAL as a piggyback ended up being just fine. It worked out really well.
That's fantastic. I have not done that yet. We haven't had to, but so I'm assuming you
Yeah.
put the LAL in the sulcus and then you've got some sort of normal lens in the bag.
Exactly. Yeah, one in the bag, one in the sulcus.
Cool. Yeah, I have not done that. What about cylinder? Is there a lot of cylinder?
I've had 2 shooters, one of whom is just going through right now. He's a very high-end Wall Street business guy from the Gold Coast here, and you know, his businesses are in Abu Dhabi and Dubai and those kind of places. So he's been fascinating because he shoots both clay and he shoots iron. So you know, he's basically doing off a pistol view, and he also has clay, which you shoot off the backside of the barrel. So has anybody had any experience with this? Because he's my first, and we're really struggling with dominance at different distances with different weapons. And I don't know whether there's somebody out there that does this. I ran into a guy named Frank Lively in Jersey at my NGS meeting, and he does it. But anybody else have people? Obviously, you guys work in states where people are more active with weapons. Have you worked with that concept yet with these patients?
I have not. No, I mean, mostly what we get are just hunters, rifle hunters. Ken, what about you in the other big gun state?
Not a whole lot. I have one guy that he keeps both eyes open when he's shooting. So we had to really watch any offset we did with him, but it worked out well. Really, the best thing I could so far, and I haven't done a lot with it yet, is just talking to him. And I actually I actually did have somebody bring their weapon in, unloaded, of course, because I could see their stance, and we could kind of talk through it a little bit to help us understand what they were doing. So I don't have a hard and fast answer for that either, but sometimes I have them get out of the chair and say, show me what you're doing, and then you can start seeing what are they using, how are they doing.
I have one that does he shoots bright-eyed either for the rifle, he's with the military, and he shoots pistol with the other eye, and he brings in his slew of guns. He hasn't had cataract surgery yet, but I've had to just put lenses in front of him while he's shooting, and generally he's basically doing one with pretty much a plano eye and the other with about a plus 50 over it on the, I guess, the non-dominant, but he brings them in. I play around with it. I'm dreading when he needs cataract surgery. So.
LAL, and you can still play with it.
I still play.
Yeah, I think that's your best bet.
Ron, you mentioned doing contact lenses for these sort of things. Does anybody else use contact lenses for trialing and playing around with it?
Sometimes, yeah. Especially if they're like changing their mind so many times, and it's like, well, we only have 1 or 2 shots left. You gotta test this first, because the waving patient, the engineer that wants it precise. That way they can live it for a while.
Yeah, definitely when you're getting close to the end of the adjustment process, you're on that third or fourth adjustment and they're still really indecisive, that's the time I'll utilize contact lens trials.
That's when I pull them out. Is it's like, okay, we've done one or two here, and I feel like we're spinning our wheels. So let's get some real world experience. Let's take this and go do that.
Yeah, the problem in my experience that you find if you don't in the office, like kind of alluding to what Joe was saying earlier, having a small room and maybe you have them look out a window or something, but you know, we all know there's many different activities these folks participate in. So sometimes too, honestly, they're just frustrating and it's like, put this on, go home, live with it for a week, and then, you know, live your life and let me know what you think when you come back, and we can tweak it if we need to. So I do find it, I probably use them, you know, more often sometimes than I would like, but it's the psychology, you know, involved with them when they're going to get locked in and they can't turn back and they're just not sure if they want a little more near vision or not. There's a good example as to when I'll pull those out as well.
So I just have a question regarding that. I tend to use the contact lenses quite a lot for my patients, just because like if I'm already just for like the regular like LALs, if they're, let's say if they land at like -125 for the reading eye, I'm like, do I really want to give them more or less? You know, so we tend to trial them like a lot, and patients are really like happy like for that, because they have that ability to go home and see if they want to go from here to here. What about the plus? Have you guys noticed if there's much of a difference when trying out the contact lenses for plus? Because I feel like if you're targeting them close to -75, do they even see much of a perceptible difference when you try when you're actually doing a contact lens trial for such patients?
So when I do a contact lens trial for my patients, I don't necessarily, I'm not looking for what they see up close. Usually I'll figure that out with the trial frame in office. I'll see how well they're seeing up close with the trial frame. And with the contact being on the eye, you know, we know that it'll rough up the eye, dry out a little bit. When I do a contact lens trial, I will not do a +1/4 or a -1/4. I think that doesn't give us any information, or at least me personally. I'll do a half, but I'll check to see if they lose their computer vision or if they're just feeling offset. And those are my two things I'm looking for when I have them come back after they do a +0.5 contact lens trial. They'll likely come back and tell me that the near vision was maybe not good enough, and I'll re-demonstrate it with a loose lens and like, oh, that's clear. But my biggest thing I'm looking for is, do they feel offset or off balance? Is there too much aniso? Or did they lose computer zone or their dashboard in their car? And then the other time I'll utilize the lens is, I don't like going over -1.25. I think that when you start going over -1.25 for that near eye, they're definitely going to start giving up some computer zone. And it's sometimes hard for a patient to understand that. So I put the contact lens in so that they can check the box. They come back and they can tell me that, oh yeah, I lost this intermediate zone. There was a gap. And it will kind of help solidify that they are in the right spot for them. Sometimes people will get kind of in like analysis paralysis. And so I'll do the contact lens to help them solidify their treatment or their end target.
Yeah, I mean, maybe I'm just mean, tough love. I don't give my patients that many options. I play the I know more than you do cards, you know. But I think, Joe, to your point, like I don't ever go past 1.25, rarely, unless I've got somebody who is an established long time monovision and they want, you know, good reading, really good reading, and they're used to having like a 250 contact. We'll go to maybe 175, but that's rare. Most of the time we're at -1.25, maybe 150. And so there's only so many places to go. I've pulled a contact out. I can probably tell you on one hand how many times out of the thousands of patients that I've done with this. I don't know. Maybe I'm just a little too much tough love, but it works for me.
Yeah,
But I understand the points for sure.
yeah, I would say it's not too often that I use it, but it does come handy, and especially if you're getting kind of close to the end and they're wanting more minus, but more near vision. It's better just to kind of have it documented in the chart that, hey, okay, patient like the +50, they can handle the difference. It just kind of builds the case that this, it'll be a good treatment for the patient.
How do you do with patients who've never worn a contact before? I mean, do you have them stick it in and leave it in for a week, or what's the deal there?
Well, typically I'll put it in for them and I'll have them come back in about 2 days tops.
Okay.
Maybe over the weekend.
Yeah, we put it in like on a Thursday or whatever, and they come back. It'll be in less than a week typically.
Yeah. Ideally, and if they're taking the contact home and they've worn contacts before, I ask them to have it out by about 3 days before seeing me, just so that I have a healthy cornea, or a healthier cornea to work with.
Is anybody doing contact lens fits for the dominant eye, or just because you know what the target's going to be, it's almost always going to be plano, right? Do you always just kind of leave that one alone, or do you trial them with the dominant eye as well?
No,
I think I've
What's the
ever
goal?
done.
always the near.
That makes sense. What's your guys' treatment protocols? I mean, how often do you do that? I think I do it weekly. We do weekly visits for every patient. We try to keep them on the same day every single week. So if they're coming in on Monday, we try to keep their appointment time about the same, 10 o'clock on Monday every single week. How do you guys schedule in your office logistically?
We do weekly between treatments and 72 hours between the lock-ins.
Yep, same.
Okay.
Now, our first ones are when they schedule surgery, their first 2 treatments are scheduled a week apart. After that, I have some patients that it takes them a little while. I just said to one day, I said, I know you, and we're going to give this 10 days on this adjustment before we see you again. So most folks it's weekly, but once I get to know somebody a little bit, there are times I have to go a little bit longer.
I think patients understand that too, because I do that too, or I feel like I know you pretty well by now, and they kind of give a little smirk, half
Yeah.
laugh, like, yeah, I'm being a little crazy. Yes, you are. We need to take an extra.
Yeah, that's my code for I need you to just really just chill with this for a little bit. So
Yeah.
Some patients need time to neurally adapt as well. You get that mild offset and they feel a little funky with it. I'll ask them to come back in about 2 to 3 weeks and just see if they can notice any progress in adapting to the lens and to the offset, because everyone always wants more and more near. They want everything, right? As good as you can go. And if they come back in a week and they're telling me that they're feeling the difference between the eyes, I don't want to make it worse for them at that step. I'll tell them to, you'll likely adapt to this, where this feels like just everyday normal. You're not going to think about it anymore, odds are. And then we can start making it stronger. And they typically appreciate that approach.
we actually start using words like neuroadapt in front of, to our patients. And my favorite is when they come back and they go, I don't think I've adapted yet. Like, yes.
Mm-hmm.
I'm like, I can deal with that.
Yeah.
I do believe in it though, for sure, because I've had patients come in and sometimes you mention offsetting the eyes and they immediately are like, I've done monovision in the past. Absolutely. I don't want to do it. And it's in their mind sometimes. And I'm just like, you're doing so good. Just give it a little more time. And, I'll even see their near vision will check and it'll be like J2, J3, and I'm expecting more of like a J1 or so with what their vision is, but I just feel like they haven't adapted, or they're not trying to really read the letters. And then I have them back and they're reading that J1 because they've had that extra little bit of time to adapt to it. So I do truly think giving extra time is always helpful for the patients.
Yeah.
And you
I
can
don't know about the control
typically
groups,
figure
there's
out.
only- Yeah. No, go ahead, Joel.
Well, you can typically figure out if they are really having a hard time neurally adapting, because you can close down their distance eye with like an occluder, and if their near vision gets better, then you know that they're having troubles adapting because their brain's taking a mixture of both images and they're having a problem. And then in about a week or two, you'll do the same thing, and then they'll say, "Oh, now it looks about the same," and then you know that they're adapting.
Yeah.
And they loved it. Like, oh yeah, now it looks the same. And I'll tell them that too, because just like eventually you're gonna appreciate looking at it with both eyes, even though this one here is not seeing much. It'll find ways of helping it out, and you'll actually appreciate it versus, wanting to close your eye to see it better.
That's a good thing. I talk to my patients around because I walk in, especially in their second treatment or the first time after their first treatment, and they're starting to compare before we even start talking about it. And I get in their face a little bit, like, stop doing that. You're making my job a lot harder if you compare. It's like asking me to throw a baseball with my left hand. It's going to look terrible, but they're physically and medically the same, right? It's because we have dominance. But man, if you give me 100 pounds to carry upstairs, it is nice to have them both. Same with the eyes. They have different pros and cons and different things that they're gonna be better at. So don't compare them because you're just killing yourself, and you're making me
I
frustrated.
tell them you're training your brain to separate instead of work together. Stop doing that. You're working against yourself. And if you do it again, I get to whap you upside the head.
Yes. Yeah, this is me asking you nicely to stop doing that, but
I am
clubs
not
come
above
up.
whapping a patient upside the head. It's gentle. I
It's
have a
in our
witness in the
consent
room.
form.
It's okay.
It's in our consent form. I'm allowed to. You signed it.
Another thing that they won't notice though is if say you have a patient, plano and -1, and they keep on telling you that I see better with my +150 readers, and I'll tell them, well, you're just doing it with one eye, and I'll put the +150 in their dominant eye, and they're like, wow, that's really clear, and I'll switch it over to the other eye, like, oh, that's blurry, and I'll tell them like, hey, look, you're able to do this with with one eye. It's just that you like to do it with your favorite eye right now because it's always the lead player. It's always has been. Your non-dominant's been kind of the helper. Now it needs to play like more of a main role, and you just need to give it time to adapt, to start, working harder, and it's going to become more and more natural. But they'll be surprised that they're wearing these +2 readers or +150 readers, and they're only doing it with one eye, and they had no idea. And that's kind of like an aha moment for them, like, hey, this is okay, we can do this with just one eye. I just need to give it some time.
Yeah, it's a good strategy.
Yeah.
Well, guys, we're coming up on an hour. I mean, we only got through, a couple cases here. Let's save the rest of them for next time. We'll do this again in like a month or so. Just keep your eyes on an email. I'll have this recorded, and it's all recorded. It's going to be posted on the website, Peer-to-Peer Academy. I'll send a follow-up email too. So if you want to rewatch it, we covered a lot of great ground. Thanks for all the input and the open discussion. I think this is great.
Awesome.
Thanks, everyone.
All right, guys.
Yeah, thanks,
Bye.
everyone.
Good night.
Thank you.
Have a good night.
Thanks.